to patient presenting with abdominal pain. Am I audible to all of you? Can you give me a thumbs up if I'm audible, live and clear? ओके अगर आप कंफर्म करोगे कि मैं लाइव हूँ तो फिर देन आई स्टार्ट. ओके सो आई एम विजिबल नाउ.
Yes, sir.
ओके ठीक है देन गुड आई स्टार्ट. Good evening everyone and welcome back. So there were some technical difficulties, we had to sort that out, sorted. So we'll start with the topic now. So today we're going to discuss about acute pericarditis, but before we get into the topic, let me first classify the pericarditis based on the duration, and then we will take up the acute pericarditis. Well, we know the basics. Pericarditis refers to inflammation of the pericardial layer, which is the membrane covering the heart, right? So when pericarditis happens, if the duration of the illness is less than 6 weeks, then we call it as acute. Good evening everyone, good evening. And if it is more than 3 months in terms of duration, then we call it as chronic. But if it is between 6 weeks, means more than 6 weeks but less than 3 months, we can call it as incessant pericarditis. So incessant refers to duration more than 6 weeks but less than 3 months. This in conventional terms we also call it as subacute pericarditis. You can also call it as subacute pericarditis. We will be discussing the incessant and the chronic pericarditis in another session. Today we will be talking about acute pericarditis. Okay, so what is acute pericarditis? Inflammation of the pericardium lasting for less than 6 weeks. We are going to call it as acute pericarditis. Now what can cause it? What are the common causes for acute pericarditis? Now, as I have already told you, pericardial inflammation need not always be because of infection. So that is why acute pericarditis causes can be classified as infectious and non-infectious. Each and then Patra, I am scheduling another session for the part 3 of cardiomyopathy. It will be done soon. Okay, so we'll divide that into infectious and non-infectious. First of all, infectious are much more common than non-infectious. That is why I'll start with infectious. But before even I make a list of infections known to cause acute pericarditis, let me tell you, more than 50% of acute pericarditis cases, we will never get to know what is the cause. We will never get to know what is the cause. So in such cases, what do we call it as? Idiopathic. So if you're seeing 100 patients of acute pericarditis, more than half of the cases, you will never get to know what was the reason, which infection, which non-infectious condition was responsible. In the remaining half of the cases, we will be able to identify the causes. Okay, so when it comes to infectious, viruses are the most common infectious cause for the acute pericarditis. That includes viruses like Coxsackie viruses, echoviruses, then adenoviruses, Epstein-Barr virus, as well as, how can we forget, HIV. I've told multiple times that HIV will be an answer in whatever disease you think about, because HIV is known to cause myriad manifestations, including acute pericarditis. Bacteria can also cause acute pericarditis. When it comes to bacterial causes, mainly we have to remember streptococci and staphylococci. These are the leading causes. Other bacteria can also cause, if there is bacteremia, if the bacteria are circulating in the blood, they can also go to pericardium and infect it. Okay. When it comes to fungal causes, Candida, then coccidioidomycosis, these are known causes for pericarditis. And as we already know, tuberculosis can also cause acute pericarditis, typically more common in countries like India or what Western world calls as the third world countries. Now there are also non-infectious causes, and among the non-infectious causes, the most common non-infectious cause is trauma. And when I say trauma, please remember, trauma need not always be because of road traffic accidents or penetrating injuries. Like typically if someone takes a sword or a knife and stabs the chest, it may injure the pericardium and the injury will trigger inflammation. Apart from that, even surgical trauma, like when you do open heart surgeries, you have to cut open the pericardium and then reach the heart. In such cases, we are also inducing the inflammation of the pericardium. So trauma can be either the non-surgical trauma or it can even be surgical trauma. non-surgical as well as surgical trauma. Okay, drugs are also known to cause acute pericarditis, and when it comes to drugs, the first important drug I want you to remember is d-penicillamine. D-penicillamine. Apart from that, procainamide or procainamide, and then fluoroquinolones. These are all known to cause acute pericarditis. Okay. Then apart from that, autoimmune disorders are also known to cause acute pericarditis. And when it comes to acute pericarditis, I want you to remember one important point. You open up any rheumatology chapter like SLE, and then go to Harrison and read what is the most common cardiovascular manifestation of SLE. The answer is acute pericarditis. Go to rheumatoid arthritis and read what is the most common cardiovascular manifestation of rheumatoid arthritis. The answer is acute pericarditis. So majority of rheumatological disorders, the most common cardiovascular manifestation will be acute pericarditis. So diseases like SLE, rheumatoid arthritis, systemic sclerosis, mixed connective tissue disorder. In all these cases, we can get acute pericarditis. But there is one more autoimmune pericarditis that we need to remember, which is called as Dressler syndrome. How many of you know Dressler syndrome? Dressler's syndrome. Good evening, everyone. Good evening. Dressler syndrome refers to post-MI pericarditis, that to late post-MI pericarditis, means after an episode of myocardial infarction, usually 2 to 6 weeks later, patients develop chest pain again, and this time it is not because of another episode of MI, but rather because of the inflammation of pericardium. So we are going to call it as late post-MI pericarditis, which is believed to be autoimmune in origin. Means when we have myocardial infarction, we would have released some myocardial proteins. Body might have produced inflammatory autoimmune response against these myocardial proteins. And because the pericardium may have structurally similar proteins, the autoimmune attack may happen to pericardium, giving rise to autoimmune pericarditis. So Dressler syndrome is also an autoimmune pericarditis, which typically happens 2 to 6 weeks after myocardial infarction. Again, I'm reiterating, 2 to 6 weeks after myocardial infarction. And last but not the least, very, very important point, apart from asking drugs known to cause pericarditis, Dressler syndrome, they have repeatedly asked about uremia. So when we have chronic, or even for that matter, acute severe renal failure, blood urea level increases. Urea is toxic to pericardium. It causes inflammation of the pericardium. Why this is important? Because when uremia causes pericarditis, it is usually painless. It is usually painless. So these patients may not even develop pain as a symptom. But recognition of this patient's pericarditis is very, very important, because we know that uremia increases the risk of bleeding. That is why many CKD patients often bleed. Plus, if it is a case of CKD, he may be on dialysis. During dialysis, he may be receiving heparin. That also increases the risk of bleeding. So now if bleeding happens inside the pericardial cavity, that can compress the heart and can lead to what we call as cardiac tamponade. So uremic pericarditis does carry the risk of developing cardiac tamponade. And then if I want to avoid this all consequences, then I have to recognize uremic pericarditis early and treat. So please remember, these patients are going to be painless pericarditis, and that is why high index of suspicion is very, very important. So if you have a patient with CKD, you know that their urea level is high, then you should always keep in mind that this patient may go on to develop uremic pericarditis, and I should be closely monitoring the patient. And if at all patient develops uremic pericarditis, how can I treat it? Is there any way I can reduce the blood urea levels other than dialysis? The answer is no. If kidneys fail to excrete urine, I can give diuretics and still extract some work. If kidneys are not able to excrete potassium, your blood potassium level is increasing, then I have dextrose with insulin, I have potassium binding resins, I can use salbutamol nebulization. I have various ways to treat hyperkalemia of the patient. If there is metabolic acidosis because of renal failure, I can still use sodium bicarbonate to get the pH back to normal range. But if urea level is elevated and it is causing symptoms, dialysis is the only way. And that is why uremic pericarditis becomes an indication for hemodialysis. So you have to remember this one point extra. Okay. So summarizing, what is acute pericarditis? Inflammation of the pericardium of less than 6 weeks duration. What can cause it? It can be infections as well as non-infectious causes. But remember, more than half of the cases we never identify any cause. That is why idiopathic is the most common cause. followed by infectious. Among infectious, viruses are the most common cause. Among the non-infectious, drugs causing pericarditis is a repeatedly asked MCQ template. And apart from that, Dressler syndrome, what is it? It is late post-MI autoimmune pericarditis and then uremic pericarditis. Okay, so now we know the causes for acute pericarditis. Let us look at the clinical features. Obviously, pericardium is inflamed. That will trigger pain. Where? Obviously, chest pain. So these patients present with chest pain. Now, these patients' chest pain become an important differential diagnosis for patients with MI because MI is also an acute condition. Acute pericarditis also will present with acute onset pain. So if a patient says that last 5 to 6 hours I'm having chest pain, MI is obviously a possibility. It's always a priority number one differential diagnosis. But acute pericarditis is also a possibility. Now, how do I differentiate between the two conditions? Okay, now the location of the pain. The chest pain that we get in acute pericarditis is retrosternal. Retrosternal. Okay, so now MI pain is also retrosternal behind the sternum. Then how do I differentiate? The nature of the pain is the first differentiating clue. The pain here is usually sharp, stabbing, or penetrating in nature. Sharp, stabbing, or penetrating in nature. On the other hand, the pain of MI is usually squeezing type. The patient usually says that some heaviness or some squeezing sensation I'm feeling in my chest. That's the usual description of angina or MI pain. These patients feel like someone is stabbing or something is penetrating into my chest. That is a description of the pain. There's another point that will help us to differentiate acute pericarditis pain from MI. What is that? If I have MI or if I have angina, will the pain have any relationship with my position? Whether I'm sitting upright, whether I'm lying down, whether I'm turned to one side, the pain of angina will persist. It will have the same intensity. But the pain of acute pericarditis is going to change according to the position of the patient. So it is worse on lying down. It is worse on lying down. And second, this pain is also having a relationship with respiration. On the other hand, anginal pain or MI pain, it has no relationship with respiration. Whether I'm taking an inspiration, whether I'm doing an expiration, the pain will be of same nature. But here, it is worse on lying down and it is worse on inspiration. Worse on inspiration. So these points will help me that it is worse on lying down. So that has a relationship with the posture. It is worse on inspiration. In terms of nature, it is penetrating in nature. These points will help us to differentiate the MI pain versus acute pericarditis. Now the question is, why does this pain have a relationship with the posture of the person? Why does it have a relationship with the respiration? When MI pain doesn't have, why pericarditis pain has a relationship? Remember, we know that our pericardium has two layers. One layer which is adherent to the myocardium. So if this is the heart that I'm sketching, then around that attached to the myocardium is a layer of the pericardium which we call it as visceral pericardium, right? We call it as visceral pericardium. Then I also have one more layer of the pericardium which is slightly separated from it, and I will name it as the parietal pericardium. So there is another layer of the pericardium which is called as parietal pericardium. Now the pain is produced by the rubbing of two layers of pericardium. Normally the two layers are decently separated. We will have around 10 to 20 ml of fluid lubricating this space. So even when heart is expanding, the two layers do not rub against each other vigorously. But now that I have the pericarditis, inflammation, so what will happen to the thickness of the pericardial layers? The thickness of the pericardial layers will increase. And once the thickness of the pericardial layers increase, they approximate each other. The two layers come closer to each other, they start rubbing, and that rubbing is producing the pain. Now, how does that explain relationship with respiration? Now think about it. Just next to the heart, we have the lungs, right? During inspiration, what happens to the lungs? Lungs are expanding because the air is entering into the lungs. Lungs are expanding. So as the lungs go on expanding, they're trying to push the two layers of the pericardium. Because lungs expanding, they're going to exert tangential pressure towards the mediastinum. So they try to crush the two layers of the pericardium. They're already inflamed. Their rubbing is going to produce pain. When we crush them together, they will produce more pain. Now, why the pain becomes worse on lying down? Why is it worse on lying down? Well, remember, heart is a suspended structure. So if I have to take this as the heart, this is the pericardium. It is a suspended structure inside the pericardial cavity. When you lie down, the heart comes to rest in the pericardial cavity, making the two layers of one which is adherent to the myocardium and the one parietal. The adherent to myocardium is visceral and the one on the outside is parietal. Because heart rests inside the pericardial cavity when we are lying down, the two layers come closer, they rub against each other, and that produces the pain. So these points will help us to differentiate the pain of acute pericarditis from pain of MI. And for this reason, this pain is also called as pleuritic type of pain. This is called as pleuritic type of pain. Now, why am I using the term pleuritic type of pain? Because when I have pleuritis, I get the same nature of pain. What is that? Two layers of pleura. We also have visceral and parietal pleura. When the two layers get inflamed, they may rub against each other and they produce pain. There also during inspiration, lung is expanding, two layers rub against each other, produce more pain. That is why this is called as pleuritic type of pain. Pleuritic type of pain. So if I get a patient with acute onset chest pain, which he says that when I lie down and when I'm taking deep breath, it hurts more. And when I sit upright, it feels a little relieved. And when I'm doing expiration, it feels little relieved. Clinically, I can suspect that it is a case of acute pericarditis. Now, when I go for examination, what do I find? If two layers of the pericardium are rubbing against each other, I can hear that rubbing noise. Like if you take two sheets of leather or two leather wallets and rub against each other, you can hear that rubbing, right? So same thing, two layers of the pericardium are rubbing against each other and we can hear that sound. When we hear that sound, we call it as pericardial rub. You can also call it as pericardial friction rub. We will call it as either pericardial rub. You can also call it as pericardial friction rub. Now the only problem here is if I have, let me say, pleuritis, inflammation of the pleura, the layers covering the lungs. There also I will have pain which will be worse on inspiration. There also when two layers of pleurae rub against each other, I will hear this rubbing sound. There we call it as pleural rub. Now what I'm hearing, whether it is pleural rub or pericardial rub, how will I differentiate? Because lungs extend very close to mediastinum. So if I'm hearing something here, it may be coming from the pleura or it may be coming from the pericardium. How will I ensure that the rubbing sound that I'm hearing is coming from the pericardium and not from pleura? Remember, why the pain is increasing on inspiration? Because the two layers come closer, right? Okay. So rub also increases during inspiration because the two layers come closer. But as long as heart is contracting, some amount of rubbing will be continuously happening. So all I have to do is ask the patient to hold the breath. If it is pleural rub, the lungs are no more moving. The two layers are not going to rub against each other, the pleural layers, and the rub will disappear. But if it is pericardial rub, even if the patient holds the breath, heart is going to contract continuously. Some degree of friction will happen and I will continue to hear the rub. So please remember, pericardial rub persists on breath holding, while the pleural rub disappears on breath holding. So you can make a note, pleural rub disappears on breath holding. So this point helps us to differentiate between pleural and pericardial rub. Okay, so now I got some clinical clues, examination wise and history wise. History wise, retrosternal chest pain, which has a relationship with posture. It is worse on lying down and it is also having a relationship with breathing. It's worse on inspiration, and when I put my stethoscope on the patient's precordium, I hear a rubbing noise, which we will call it as pericardial rub. Just to make sure that this is coming from the pericardium, I will ask the patient to hold the breath. After holding the breath, if the rub disappears or diminishes, then it is pleural. Does not change, then it is pericardial. Now from the clinical suspicion, how will I take it to the diagnosis? Few seconds of breath holding is enough, Sudhapar. By that time, we will have the clarity whether the rub is disappearing or persisting. If it is persisting, it is pericardial. If it is disappearing, it is pleural. Okay. ECG and echocardiography are the two investigations that will help us to reach the diagnosis. Now, what do I get on the ECG in these patients? In a patient with pericarditis, when we do ECG, we get ST segment elevation. ST segment elevation. Can anybody tell me where else we get ST segment elevation? Of course, ST elevation MI. So patient came with chest pain, retrosternal. I got an ECG done. It shows ST elevation. Then how do I conclude that this is pericarditis and not ST elevation MI? Because in MI also, patient will have retrosternal chest pain. Can I be confident in ruling out MI just based on the history? No. I need a conclusive evidence to say that this is not MI and rather it is pericarditis. Aryan Hussain, very good point. So the ST segment elevation that we see here has certain points which will set it apart from the ST elevation that we get in MI. First point, normally in MI, we do see something called as reciprocal changes. Now, what do I mean by that? When we look at the heart, different parts of the heart are represented by different leads, and some leads have reciprocal leads. Means, for example, our higher portion of the lateral wall here, this portion is represented by 1 and AVL, and the inferior wall is represented by 2, 3 and AVF, as we know. Now these two are looking at the same walls in the diagonally opposite direction. So we call them as reciprocal leads. Means what? If I have inferior wall MI, inferior leads, which is 2, 3, AVF, are expected to show ST elevation, right? And if that is the case, the high lateral leads, that is 1 and AVL, are expected to show ST depression. This is what we call as reciprocal changes. Presence of reciprocal changes on the ECG is the surest sign of MI, right? But in case of pericarditis, we will not see these reciprocal changes. Means what? Inferior leads as well as these leads may show ST elevation. There will be no reciprocal changes. That is the first point. So ST segment elevation in multiple leads without reciprocal changes. That is the first point. Second thing that will help you to differentiate the ST elevation that we are seeing here, right? The ST elevation is usually concave. Means what? If this is my ST segment, the ST segment can get elevated like this, then it is convex, or it can get elevated like this, then it is concave. So we generally see concave ST elevation. In fact, you might have come across images of patients with the ST elevation MI, where what you notice, you get convex ST elevation, and in fact this convex ST elevation, we call it as tombstone sign, right? Because it looks like those grave pe jo hum dalte hain na, tombstones, like when you have the graves, you put those tombstones, it kind of looks like that. That's why it is called as tombstone sign. So similar kind of ST elevation you get in MI, but here you get concave ST elevation. That is the second point. Then the third point that is going to help you. Is, please remember, when you talk about MI, only ST segment हिल जाता है, मतलब only ST segment is altered. But in patients with acute pericarditis, ECG में जितने भी segments हैं, सब हिल जाता है. मतलब all the segments are disturbed, not only one segment. MI only ST segment is disturbed. Now what other segments I get? We have something called as PR segment, ST segment, and between the T wave of one complex to the next P wave, we have a segment which is called as TP segment. So this is TP segment. Here to here is TP segment, and then here to here is the ST segment, and from here to here is the PR segment. All the segments are disturbed. So what do I mean by that? PR segment goes into depression. Depression means it will come below the baseline. If this is the baseline, PR segment will be below the baseline. ST segment goes into elevation, as we have already looked at. Means ST segment comes above the baseline and it is usually concavely elevated. And then third, TP segment, this segment starts on the baseline, but as I go further in the ECG, the TP segment goes down. Means it is not depressed from the beginning. It is starting on the baseline and then goes down like this, and then we will have the next P wave. So this downsloping TP segment is what we see in these patients. So TP segment will be downsloping, and this downsloping TP segment is also known as, there is a sign, there is a name given to this sign. It is known as spodic sign. It is known as spodic sign. This is an MCQ that they have repeatedly asked in the NEET PG as well as FMGE. Where do you get spodic sign? We get that in patients with acute pericarditis. So what we learned today, number one, ST segment elevation, that will be concave, and it is not going to follow the reciprocal rule. Reciprocal changes will not be seen. Number two, PR segment will be below the baseline, depressed. And number three, TP segment starts on the baseline, but as we go forward, it goes on depressing downwards. That is, it is downsloping. We are going to call it as spodic sign. Right? Let me write down these points. There will be PR segment depression, and the fourth point is there will be downsloping TP segment, and this downsloping TP segment, we call it as spodic sign. So I have a ECG attached here where we can clearly see all the findings that I just briefed you. Okay. So let me take your attention to lead 2, right? Lead 2. Can anybody identify where is the ST segment? Where is the ST segment, or how to recognize the ST segment on the ECG? Please remember, ST segment begins with what we call as J point. अब ये J point क्या होता है? जहाँ पे QRS complexes end होता है और वहाँ से एक angular change दिखाई देता है. For example, the sketch that I had done here, QRS कहाँ पे end हो रहा है? यहाँ पे, right? So I can clearly see an angle from which the segment is beginning. So this point we call it as J point. In simple words क्या है? S wave का end point will be called as J point. अगर किसी lead में S wave नहीं दिखता, you don't see S wave, then the end of R wave will be counted as J point. जहाँ पे भी R wave end होता है, that we will call it as J point. Right? So if the J point is above the baseline, if it is like lifted above here or somewhere here, then we will call it as ST elevation. So like you see in this ECG, what is J point? The end of S wave. अगर S wave नहीं दिखता है तो the end of R wave. So here, this is my R wave. I don't see anything coming below the baseline, right? So the R wave ends here. So this I will count it as J point. So if I have to look at the baseline of the ECG, this is significantly, right? R wave is starting here. So that will be counted as baseline. So compared to that, this point is high, right? This is my T wave. This is my P wave. So this point is definitely above the baseline. So that means ST segment elevation here. Second, now when I look at the segment, this is T wave. This is the end of R wave. So यहाँ से यहाँ it is concave, right? So this is a concave ST segment elevation that we were talking about. Concave ST elevation. Now this is P wave. This is T wave. So the PR segment is depressed. There is depressed PR segment. And now look at the end of T wave. And this is P. This is T. The end of T wave is here. So this will be the TP segment, which is starting higher and then descending downwards. Start ऊपर हो रहा है, यहाँ पे start हो रहा है, and then it is going downwards. Starting, like look at here, starting at this point, going downwards. So this starting at higher point, then going downwards is what we call as spodic sign. Spodic sign. So these 3 points will help us to recognize the acute pericarditis on the ECG. Compare that to a patient with MI. What do you notice? Patients with MI will not have PR segment depression. They will not have the down sloping TP segment or spodic sign. And the point I told you that MI patients will have reciprocal changes. Now look at this. We see ST elevation in lead 2. Now here also, look at lead 3. This appears to be the baseline. R wave यहाँ से start हो रहा है, ends here. This is apparently the T wave, and this is the concave ST segment. So that is above the baseline. Clearly above the baseline. ST segment elevation lead 3 में भी है, 2 में भी है, and I think you can also agree that there is ST segment elevation in AVF also. P wave, PR segment, R wave ends here. R wave is ending quite above the baseline. So this is the ST segment and this is the T wave. So this is the ST segment. this segment, concave and above the baseline, elevated. So lead 2 3 AVF, I'm seeing ST elevation. If it was a case of ST elevation MI, not pericarditis, then what one and AVL should show? What do I expect in one and AVL if it was STEMI? There should be ST depression, right? That is what we call as reciprocal changes. Lead 2 3 AVF के लिए 1 and AVL are reciprocal leads. They are looking at the same part of the heart diagonally in opposite direction. So अगर एक में 2 3 AVF में ST elevation दिखता है तो 1 and AVL में ST depression दिखना चाहिए. But what is happening here? Look at the J point. J point is quite higher than the PR segment, right? So this is my T wave. So it appears that the J point is again higher. That means I'm seeing ST elevation. If it was STEMI, what would I have seen? I would have seen ST depression here. So rule of reciprocal changes is clearly broken. So I have ST elevation without reciprocal changes. First point done. We have seen that the ST segment elevation is concave. We have also seen that the PR segment is depressed, and we have also seen the downsloping TP segment. So this is a classical ECG of acute pericarditis. What else investigation I can do? I can do the echocardiography. What echocardiography will show me? Because there is inflammation of the pericardium, some amount of inflammatory fluid will be leaking into the pericardial cavity. So there may be pericardial effusion. There may be pericardial effusion, which I can clearly see on the echocardiography. Like I have attached an echocardiography image where you can see the left ventricle, right ventricle, left atrium. यहाँ पे right atrium होगा, and around that you can see the pericardial space or pericardial cavity. Here there is a separation because all this black you're seeing is the fluid, that is our pericardial effusion. So echo में बस उतना ही दिख सकता है, there may be pericardial effusion. ECG holds the important role in the diagnosis of acute pericarditis. What is happening here? 3 segments are disturbed. What are those? PR segment. PR segment के साथ क्या हो रहा है? Depressed. MI में ये नहीं होता है. Second, ST segment. ST segment के साथ क्या हो रहा है? ST segment is getting elevated. What type of elevation? Generally concave elevation. MI में क्या होता है? Convex elevation. Third point, TP segment. TP segment के साथ क्या हो रहा है? TP segment start तो baseline पे होता है, right? On the regular point, but as the TP segment progresses, it depresses or downslopes, which we call as cardiac sign. So with the ECG, once you have diagnosed that it is a case of acute pericarditis, now how will I manage? Point number 1. पहले ही बोल दिया है that more than half of the cases we will not get to know what is the cause. When I don't know the cause, what can I treat? If I know it is because of bacteria, I can give antibiotics. If I know it is because of fungi, I can give antifungal. I know if it is because of drugs, I will stop the drugs. If I know it is because of uremia, I'll take the patient for dialysis. And if I know that this patient is having autoimmune disorders, then I will treat the underlying autoimmune disorder like SLE, rheumatoid arthritis. But आधे से ज़्यादा cases में we will never get to know what is the cause. So how will I manage those patients? So first thing is treat underlying cause if it is treatable. If you are not able to identify any underlying cause where you can offer treatment, then the solution is we have to give them anti-inflammatory agents. So what will be the first line treatment? The first line anti-inflammatory agents will be NSAIDs. But NSAIDs alone is generally not enough. Or I do not want to use very high dose of NSAIDs because you know NSAIDs have an impact on the platelet function. And if I use very high dose of NSAIDs to achieve the inflammation control, I may disturb the platelet function. And in a case of pericarditis, that can be problematic because what if bleeding happens into the pericardium? Patient will end up developing what we call as cardiac tamponade. I think Sutapa was asking me what is cardiac tamponade, right? What is cardiac tamponade? Basically collecting too much of fluid into the pericardial cavity so that it will compress the heart. Once we compress the heart, we will not be able to fill the blood into the heart. So once we lost good amount of ventricular filling, the blood जो ventricle से eject होगा वो भी कम होगा. So we'll have severe reduction in cardiac output. Patient's BP will drop. It will lead to a lot of consequences. It is a life-threatening emergency. So obviously I do not want to get into it. So I want to use NSAIDs but not at full or very high doses. So I want to get the anti-inflammatory action partly from another drug. So that when I use 2 drugs with anti-inflammatory properties, I can minimize the dose of NSAID. Thus, platelet dysfunction can be minimized and the chances of causing or inducing cardiac tamponade or hemopericardium can be reduced. So yes, NSAIDs, mainly aspirin is one of the preferred agent, plus I want to add another anti-inflammatory agent, and it is not steroids. Steroids are our second line agent. So can anybody tell me which anti-inflammatory agent comes to your mind, which is not NSAID, which is also not a steroid, which is not a corticosteroid? I'll give you a clue. We use this anti-inflammatory agent in patients with acute gout to relieve the inflammation in gout. So which agent I'm talking about? Right, that is colchicine. So colchicine plus NSAIDs are considered as the first line treatment apart from treating the underlying cause if it is treatable. Like अगर bacterial है तो antibiotics, fungal है तो antifungals, uremia है तो dialysis. Right? Apart from treating the underlying cause, to reduce the pericardial inflammation, first line agents are combination of NSAIDs and colchicine. Colchicine add करने से advantage क्या होता है? Advantage of adding colchicine is I can minimize the dose of NSAIDs. But if with that also, if patients pericarditis is not coming under control, then we think of starting with steroids. Now, because in half of the cases we never get to know what is the cause, there's also a problem that the pericarditis may go on recurring. Because agar underlying cause pata hai, we can treat it and we can minimize the recurrence. Like if I get to know that patient is CKD and uremia is causing pericarditis, I will initiate dialysis, and as long as I'm regularly doing the dialysis, subsequent episodes of pericarditis are prevented. But if I do not know, half the cases I do not know what is the underlying cause, how will I treat if it is recurring again and again? So if it is recurring again and again, and is that a problem? Well, that is a problem. Why it's a problem? Because whenever pericarditis happens, pericardium is inflamed, and when it heals, it will heal with some amount of scarring. अगर ये बार बार होता जाता है, recurrent attacks of acute pericarditis, pericardium goes on getting scarred, and when multiple scars are formed in the pericardium, right, हर बार pericarditis, some amount of scarring, then eventually what happens? The entire pericardium is severely fibrosed or scarred, and once that happens, it will lose its elasticity. It will not allow the ventricle to expand, and in that case, the situation will be called as constrictive pericarditis. So recurrent acute pericarditis is the leading cause for constrictive pericarditis. अगर बार बार pericarditis हो रहा है तो somewhere down the line patient will develop constrictive pericarditis. So prevention is important. But if I do not know the cause, then how would I do? Well, there are two choices that we can offer to patients who are experiencing recurrent acute pericarditis without clear-cut underlying cause. First thing is we can use an anti-interleukin-1 monoclonal antibody, which is, interleukin-1 is a potent inflammatory cytokine. अगर इन्फ्लेमेशन को ही ब्लॉक कर दिया, अंडरलाइन कॉज तो पता नहीं, इन्फ्लेमेशन को ब्लॉक कर दिया तो पेरिकार्डियल इन्फ्लेमेशन नहीं होगा, इन्फ्लेमेशन नहीं होगा तो स्कारिंग या फाइब्रोसिस नहीं होगा, फाइब्रोसिस नहीं होगा तो कंस्ट्रक्टिव पेरिकार्डाइटिस भी नहीं होगा. But obviously it's an expensive drug. So for those who cannot afford it, the next best alternative is pericardial stripping. Now what do I mean by that? Can a person live without the pericardium? Yes, without any major problem, a person can live without the pericardium. अगर बार बार acute pericarditis हो रहा है और उसके वजह से अगर पेरिकार्डियम फाइब्रोज होके आगे जाके कंस्ट्रिक्ट करना है, उससे पहले ही पेरिकार्डियम को निकाल देते हैं, सर्जिकली रिमूव द पेरिकार्डियम. वी कॉल दैट एज पेरिकार्डियल स्ट्रिपिंग और पेरिकार्डियक्टमी. आगे जाके ये प्रॉब्लम करेगा, प्रॉब्लम करने से पहले ही हम उसको निकाल देते हैं. And for those who can afford, we have a better drug, which is anti-interleukin-1 monoclonal antibody called as anakinra. Which is a monoclonal antibody against interleukin-1. So this is how we manage a case of acute pericarditis. Before we sign off, one little question. Anakinra, where else we use it other than acute pericarditis? So the colchicine is also an anti-inflammatory agent, which has no major impact on the platelet functions. So NSAIDs have an impact on the platelet function. So using very high dose of NSAIDs to achieve anti-inflammatory activity does run the risk of disturbing the platelet activity. And in a patient with pericarditis, that is a problem. If I have some joint pain, osteoarthritis, maybe I can comfortably use high doses of NSAIDs. But in patients with acute pericarditis, I want to limit the use of NSAIDs because higher the dose, more is the impact on the platelet function. And if there is bleeding in the pericardium, where like you already have inflamed pericardium, so bleeding may happen, and high dose of NSAIDs may increase the chance of bleeding happening. Bleeding into the pericardium will lead to problems, right? It will compress the heart and cause cardiac tamponade. वो नहीं चाहिए, इसलिए NSAID का यूज मैं मिनिमाइज करना चाहता हूँ. And when I want to do that, मुझे कुछ और drug की help चाहिए to achieve that anti-inflammation, the degree of anti-inflammation that I want. Colchicine being an anti-inflammatory agent, वो मेरे लिए काम आएगा. That's why we are combining the two drugs. Adenosine, absolutely right. Yes, we use it in rheumatoid arthritis and familial Mediterranean fever. So in familial Mediterranean fever, those patients have mutations in the interleukin 1. So because of that, their body produces high amount of interleukin 1 for trivial stimuli or sometimes without any stimulus. And whenever interleukin 1 levels surge, there will be inflammation in the body, primarily affecting the joints, mainly the ankle joints. So they present with ankle arthritis. Along with that, they can also have peritonitis, pericarditis, pleuritis, and even sometimes meningitis along with the fever. Is there any infection responsible for familial Mediterranean fever? No, just a genetic mutation disturbing the functions of interleukin 1 is the reason. So we call that category of disorders as auto-inflammatory disorders. मतलब यहाँ पे autoimmunity नहीं है. Your B lymphocytes are not producing antibodies targeting some tissue. Your cell-mediated immune system is not causing direct damage to tissues. It is the increased expression of interleukin 1 at inflammatory cytokine. So that is why those disorders are called as auto-inflammatory disorders. A classical example is familial Mediterranean fever. वहाँ पे भी for treatment we use anakinra, and in the past, not today, but in the past we used to use anakinra for treatment of rheumatoid arthritis. But जब से anti-TNF alpha drugs आए हैं, they have replaced the role of all other older generation of drugs. So we still use methotrexate, hydroxychloroquine, leflunomide, and then when we think of biologicals, first thing we think of is TNF alpha blocking agents when it comes to rheumatoid arthritis. But still, familial Mediterranean fever ke liye, this is a very, very important drug, and for acute pericarditis, we can consider using it. Okay, so that's it for today, guys. We will be signing off. I think we are getting into the Deepavali holidays. I wish those who are celebrating Deepavali, happy Deepavali now in advance. And once we're back from the Deepavali holidays, we will get going with the remaining chapters. We will be doing one session on the myocardial diseases, including the myocarditis as well as the pending cardiomyopathy parts. And we will also be doing a topic where we will be discussing the constrictive pericarditis. And then after that, we will get into some requests that I had received with respect to neurology. We'll be doing a session on multiple sclerosis. So that is in line for the next 2 weeks. After that, as per your demand, we will reschedule the sessions. Thank you guys. Have a good night. See you soon. Bye-bye.